Thanks, Dr. Asher, and I'm really pleased to be here speaking on this important topic. So many of you will be aware of radiation-associated heart disease. We know that there are multiple thoracic malignancies that are radiation sensitive, but they are obviously in close spatial orientation to the heart. We also know that data supports the use of radiation, and so we just need to make sure we do that in the most appropriate way. Historically, the doses have been very high and in wide field, and at the time, let me be clear, that was the right thing to do for the patients. The patients who did not receive this treatment at that time no longer lived to survive and tell the tale. So the first thing that I do when I see patients in my clinic who are often very emotional and having second thoughts about their treatment choices over the years is to say, I'm just glad that they're here and that we're here to have this conversation around what to do about their heart, because if they hadn't had this treatment decades before, unfortunately we wouldn't be here having this conversation now. But it's important for us to know in current day treatment that the latent effects of these high doses present decades later on. This is most important for our patients with Hodgkin's disease who really received that high-dose mantle radiation 20 to 40 years ago. So I typically tell our fellows that I'm just in the sweet spot. I'm the perfect storm. I'm at a certain age, and a lady never reveals her age, so I'm not going to tell you how old I am. But my patients are those patients who received their high-dose radiation in the 70s and 80s. Ben Allen, Cherry and co might see a few of these, but by the time Ben gets to the end of his career, hopefully we won't be seeing any of these patients because they will have had the more modern therapies with the lower radiation doses. We now have very strict protocols that are optimized to target the tumour and minimize the surrounding structures, and I'll speak a little bit to that. It's important for those patients who had the high doses that we understand there's a real spectrum of disease that can be preclinical to symptomatic, and patients who at the time of their treatment recall that they perhaps had some chest pain, may have had some symptoms of pericarditis, suggests that they did receive an increased dose and are more susceptible. But I'll challenge you, it's very difficult for a patient to remember how they felt 20 or 40 years ago when they were a young person with lymphoma undergoing radiation therapy. So not the world's greatest signal. What we find is that there are overlapping pathologies which leads to significant management challenges and also very non-specific symptoms like dyspnea and fatigue. So again, all things that make these patients interesting and also challenging, and we need to use our multimodality imaging to define them. A little bit about the current dose minimization techniques. We now have shielding measures, what's called advanced respiratory gating techniques with deep inspiratory breath holds and activated breathing control. So these patients, and you can see here a patient who's had a mastectomy there, they get the patient to take a deep breath in that shifts the heart away from the field that's requiring radiation to minimize the dose. You'll also see on the right there the gantries will spin, so they're giving more narrow tangential beams at different angles to maximize the targeted dose to the tumour but minimize the dose to the surrounding structures. This is the take-home slide for those of you. There's a reference here, but we put this together a few years ago to really illustrate the plethora of manifestations of radiation-associated heart disease, with a shout-out to Melinda, who's done so much work in this area. So firstly, we'll talk a little bit about pericardial disease, that constriction, the strain reversus that's already been mentioned, vasculopathy, so whether that's microvascular disease, coronary artery disease, which I'll show you an example of the real osteal location of some of these lesions, the porcelain aortas and other vasculopathy that we see, valvular heart disease, whether it's severe mitral annular calcification, calcification of the aortomitral curtain, mitral stenosis, aortic stenosis, preferentially the left-sided valves are typically affected. Moving on to myocardial disease, I think with the coronary involvement, we typically expect to see ischemic cardiomyopathies, but it's important for us to remember that this is often a diffuse process. all the myocardium has been irradiated, and often these patients will have increased extracellular volume diffusely, leading to underlying non-ischemic myocardial fibrosis, which can increase risk for diastolic dysfunction in patients who already have multiple other reasons for their shortness of breath. Conduction system disease, we often get Dr. Kanj involved with these patients who, over time, particularly with aging-related degeneration of their conduction system, have a multi-hit hypothesis there, that, and surgeries, obviously, that they have increased risk for pacemakers, and we can see there on the MRI some of the regional scar. So I'm going to speed through this for in the interests of time, but just to talk about myocardial disease, the prevalence is around 10%. Don't forget about the right ventricle, being anterior in orientation, is often susceptible to damage. And just think about the compounding cardiotoxic effects of chemotherapeutic agents, particularly anthracyclines. There is data around the cumulative multi-hit phenomenon in these patients, which can significantly impact on their myocardial function. As I said, left-sided valve disease, typically most affected, progressive thickening and calcification, accelerated degeneration, if you like. It's usually symptomatic later than coronary disease, so we often see these patients more like 20 to 30 years down the line. Typically can affect multiple valves and is often very challenging to manage. Here's an example of a patient with severe aortic stenosis, severe mitral stenosis with mitral annular calcification and mitral calcification of the mitral curtain there, the annulus fibrosa, and that's really a hallmark that I want you to remember. So these patients, when we see this calcification of the aortomitral curtain, we really should be thinking, has this person had exposure to radiation in the past? It's a pathognomonic finding, and we can see here how it is linked to survival. These patients are challenging for surgery, and really we need to be thoughtful about their approach. Pericardial disease, as we've seen already, there's certainly an underlying number of patients with pericardial problems in the community. In the setting of radiation disease, it's typically more of a calcific constrictive process with a prevalence of 8 to 30%. It can be difficult to distinguish between restrictive and constrictive disease in these patients because, as you've heard, they can have both constriction but also disease of the muscle of the heart, and that can be challenging to separate. And then the vasculopathy, which proposes many challenges, especially the logistical and the technical challenges associated with surgery. Coronary disease, typically the ostial or proximal aspects of the vessels are affected, related to the location of where the main dose was delivered around the mediastinum, the proximal coronaries, the aorta, and so forth. Microvascular disease is no doubt involved, but is less well studied and probably adds to that multi-hit phenomenon for these patients, contributing to their overall symptoms. Here is a case of a patient with Hodgkin's disease and previous radiation therapy who's got really focal proximal RCA disease, often typical of what we will see. In the interest of time, I won't go too much into this, but I think you can see how many different pathologies these patients can have, and we need to be aware of all of them. Risk stratification is really important. We need to make sure that patients and physicians are aware of this so that they can not only prepare the patient but ensure that they are followed long-term, and screening programs are recommended, ideally in centres of excellence. We do suggest that folks have screening for coronary disease from 5 years after exposure, and then for valvular heart disease from 10 years from exposure, because it is a more latent effect that we see. Going through all the different modalities, echocardiography, obviously we've heard so much in this conference of its importance. Thinking about strain imaging, here we can see severe aortic stenosis and calcification of the aortomitral curtain. Here we can see the strain reversus in the setting of pericardial constriction with really eggshell calcification surrounding the heart and reduced lateral E prime. We can see here more of a myocardial process where all the strain is reduced, both tissue velocities are reduced, more of a restrictive filling pattern, and we know that strain is also related to prognosis in terms of survival. So an important tool in your toolbox. Here are the different strain patterns: normal strain, the strain reverses pattern, and the globally reduced strain, differentiating the pattern of constriction from restriction. CT is really your friend when it comes to imaging calcification, and hence very useful in these patients for looking at valvular disease and the aorta when we're thinking about cross-clamping and cannulation for surgery. You can see some examples there of just the extent of calcification that we see in these patients. Might get you to move me forward one there if you can. Thank you. Don't forget these patients had exposure of their lungs to radiation. They often have significant pulmonary fibrosis, and Dr. Desai was able to show that this certainly impacted on their surgical risk and mortality. And then cardiac MRI, it's important to remember that cardiac MRI does not show you calcification. So it can be useful if we're looking to evaluate patients for severity of valvular heart disease, myocardial scar, perhaps constrictive physiology and deformity. But if I had to pick and I was in Australia and I only had one test, I would probably go with CT. Here we can see free breathing and flattening of that septum in the setting of constriction. Another example here of just the multiple manifestations in the one patient with examples of valvular disease, coronary disease, myocardial disease, the whole box and dice, as we would say, another patient here. And typically these patients are those with Hodgkin's disease who had exposure to high dose. I think it's important that we set the expectations of the patients. These are very high risk, and the risks are much higher than the general population. Ideally, if we're going to do surgery, it should be a one-time surgery. We know that these patients do much worse than the general population. So here, this is a take-home message really with this graph. This is the survival in the general population who have not had prior surgery. Here we have the survival of redo patients for general cardiac surgery. Here is the survival curve for patients with radiation disease having a first-time surgery. And sadly, here is the curve for redo radiation heart disease patients. So the message is, let's try and avoid the redos. It's a one-time situation, and hopefully with the advent of structural intervention, we can avoid surgery in some of these patients. So timing is key, planning is key, think about the transcatheter techniques, and then the post-operative management. Often in these patients, their lymphatics have obviously been irradiated as well. They can have real issues with management of recurrent pleural effusions after surgery to be aware of. The extent of the surgeries that these patients need is really significant. Many of you will be aware of the commando procedure, which is really reconstruction of the heart from the inside. Dr. Unai is one of our fabulous surgeons here. I've replaced old Arnie Schwarzenegger with him because it really takes a lot of guts to do these procedures. So think about multimodality imaging. It's key for assessment of these patients. Make sure that we spread awareness about this so that patients and their cardiologists and other physicians know that this is an entity. For the fellows and others, if you see this aortomitral curtain calcification, it should be your imaging hallmark. Think about screening and referral for management of these patients. And don't forget, one-time surgery is the key. Timing is critical. Set the expectations and let's do the right thing by these patients who've already suffered so much. Thank you.